So we're talking about the lower limb in today's lecture. So first we're going to look at the acute conditions and let's start. So in acute condition is any trauma or injury that results in an acute injury or sudden change or in the anatomy of the bone, which is obviously disruption in the anatomy would be a fracture or some dislocation or some tendon rupture or some injury of that sort. So we're going to look at that piece or what are the causes. So this is a pelvis. So first let's talk about this. So this is the pelvis bone, and then this is the femur. This is the head and the acetabulum. So this is the pubis, ilium, and this is ischium, right? So this is the sacral spine and the iliosacral joint. So we're going to actually repeat this again and again on radiographs, and it'll be clear how that appears, how everything is seen on a radiograph. We're going to again and again label them so everybody will understand. So now specifically let's talk about if there is some trauma to this area. So like I said, this is the pelvis, and then if some trauma is specifically towards this area of the body, then what happens is a fracture. So the fracture would be, this is the fracture of, so there is a dislocation here, a fracture here, a segment here, and a fracture segment here. So it's a very complex fracture. So this is the trauma. So if trauma or any force is an intense force or a very high amplitude force, it happens to be applied to this area of the body. What happens is it's fracture results like anywhere else in the body. So here again, let's label it. So this is ilium, ischium, and then pubis, which is forming this acetabulum here, and then this is femur. So the left side, the left femur is displaced. It is pushing into the acetabulum. The acetabulum is not anatomically congruent anymore, so it's disrupted here. So this entire fragment, this has become dislodged. This fragment has been dislodged. It's a fracture here, and this seems normal. The right femur is normal. So now here we can't really comment on if it's actually probably a male pelvis. So we're going to in a little bit discuss the differentiating features of a male and female pelvis. So for now, let's just ignore that and just focus on actually differentiating normal from abnormal. So this is an abnormal X-ray, and there are multiple fracture sites. So pubic symphysis actually seems normal, but it's displaced, like it's not in the midline anymore. But this entire radiograph doesn't appear to be in the midline because of obviously the fracture sites. There is some push and pull of the tendons, and it's not in the midline anymore. So this appears to be, the patient is actually lying straight, but this appears to be pulled up. And these fragments are also not in complete congruence. So that is how a very severe pelvis fracture presents. So it's accompanied with a lot of blood loss as well. So pelvis fracture is one of those fractures which you suspect, or which you whenever somebody comes in a trauma center, the first thing that anybody is suspecting is a pelvis fracture if there is if there are signs of intense blood loss somewhere in the body. So this X-ray is the first among the things that are first asked whenever somebody comes in a trauma center. So now here, this is a displaced, like I said, because of the push and pull mechanism. Mostly the push is dominating. So obviously this is going to be the pull and this is going to be the push, right? So this entire, this pelvis bone has has been dislodged because of fracture to the sacroiliac joint has been is no more. There's no joint anymore. The pubis is fractured. The ischium is fractured. So this entire part of the pelvis bone has been fractured and is now dislocated. So this is how a displaced pelvis fracture is, and this is a partially displaced fracture with a displacement of the femur as well. So now we're going to talk about the modalities of, and we're going to talk about X-rays. And again, let's label the X-ray and just so that everybody memorizes. So this is again ilium, this is ischium, and then pubis, the acetabulum, the femoral head, the greater trochanter, lesser trochanter, the shaft here. So this again is the acetabulum. Let's right now not focus on the fracture here. So if it were normal like this, it would have been like this, and these would have been distinct. So this is the femoral head. So again, right side and left side. And this is the fracture site here. So the acetabulum has been fractured, and these are fragments, and these are sharp ends. So this is how acetabular fracture actually can. It's very easy to actually pick up fractures in the pelvis because you have something to compare it with, right? You have this part to compare this part with. So then an abnormal thing is very easy to pick up. So when you see this here and you see this here, it's obvious that there is something wrong here. So that's how comparison actually helps you. So this is the acetabular fracture here. And then here we have a hip dislocation. So hip dislocation, let's just actually talk about it a little bit. So there's a lot of pull on the femur. There are a lot of muscles in the thigh area, in the hip area, right? So the most common type of dislocation is actually a posterior and a superior one, mostly known as a posterior slip or posterior displacement. So what happens is when the femur is posteriorly displaced, it is also moved superiorly a little bit, like I said, because of the push of the muscles, actually, or the pull of the muscles. So this is a displaced. Again, we have something to compare it with. When you compare this with this, it's very easy to pick up fractures or dislocations in the pelvis, and the major reason is because you have something to compare it with. Again, what will happen is there is going to be a leg length discrepancy, right? Because this has moved up, then this entire leg will be shorter, right? So, and it won't be able to bear any weight, so there will be no weight bearing. So those are some of the distinct features that you suspect a dislocation, and then you ask for a radiograph to confirm it. So a radiograph actually confirms the type or the displacement type of, for example, like a posterior or an anterior dislocation, but a dislocation can be picked up with physical signs as well. Like I said, leg length discrepancy will be present here because obviously it has moved up and this leg will be shorter, and this ASIS, this is the anterior superior iliac spine, has moved up as well. So there will be some hip hike as well. So this is how, this is a little bit about the hip dislocation. So this is a posterior and a superior dislocation of the hip. Now we're going to look at this. This is a CT scan. This is a cross-sectional CT scan. So what we're seeing here is the sacrum vertebral body, the ilium or the spine here, and this is, again, comparison will help you. So look at this and then look at this. So this is completely fractured here, and this is continuous, right? So you can easily pick up fractures. Again, it's very easy to pick up pelvis fractures because, well, you have something to compare it with always. So this is the vertebral body, the spinous process, and then this is the fracture, entire fracture site, and the the sacroiliac joint there is some increase in the joint space as well, but the main focus here should be this, which anyone can pick up really. So now we're going to look at the X-ray. So X-ray here shows a very large distance here, which is very visible, right? So this should be less than 4 to 5 mm, but this looks to be a little bit more than that. So, and again, let's label it a little bit. So this is the spine, and this is the sacral spine here. So this is the sacroiliac joint. Then we have the ilium, the pubis, and the ischium. This is the pubic symphysis, which two pubis bones form with one another. This is the acetabulum here and here. And then we have the femoral head, the greater and lesser trochanter. So now we're going to talk about if a person falls and which will result in an injury, right? So this is the trauma. Falling is one of a traumatic condition. So if one falls, what will happen is there will be pain, first of all. So pain is the first sign. If there is severe pain, then you suspect some internal injury, right? So then no weight bearing. Like we said, we just discussed the hip dislocation and how weight bearing, if there is a very incredibly painful condition when you bear weight on one foot, then you suspect some internal fracture or dislocation. And so weight bearing here, there is a person who has weights in his hand, but it's also when you actually stand on your feet, you're in a weight-bearing position. So as we're talking about hip, so the weight-bearing position is actually any anti-gravity position in which your lower limb is actually bearing the weight of your entire upper body and also their own weight against the gravitational force, right? So that is if that's painful, then you suspect some fracture or dislocation, right? So then we have a shortened limb, which we just also talked about that as well. So it happens with a displacement, and it can also happen with some femoral neck fracture, because femoral neck fracture actually is accompanied by superior displacement as well. Mostly it can be non-displaced, but it mostly is displaced. So leg length discrepancies can result, or a shortened limb. The involved limb or the fractured limb or the limb with the fracture or displacement will actually be shorter, right? So then rotation or any movement really will be painful or actually uncomfortable for the patient, and these are some of the signs that there is something wrong after you fall. If you experience these, or if someone experiences these, then they probably suspect some injury has occurred to their hip region. So now we're going to discuss the fractures. So again, let's label it first. So this is the sacral spine, the sacroiliac joint, the ilium, the acetabulum, the pubis, and the ischium, pubic symphysis. Now go back to imagine that this distance was so much more back when we actually diagnosed that it is more than normal, right? So knowing normal and actually knowing what normal distances are help you, and then you don't have to measure the distance to know. You just look at an X-ray or look at an MRI and you just know that there is something wrong, right? So here now let's focus on the fracture site. So this is the acetabulum, the femoral head, the neck, the greater trochanter, the lesser trochanter. So this is the fracture here, entire fracture till here, right? And this is a MRI of the same patient. So this is here it's more visible that it's a through and through fracture. So from here to here, this has been completely it's not in continuation with the rest of the bone anymore. So this is a fracture of the femur here. This is how it appears on an X-ray and how it appears on an MRI. So now we're going to talk about types of hip fractures. So this is a fracture of the neck. This area will come under the, or inside actually, the capsule of the joint, right? So the capsule of the joint will be here and here, right? So this is inside the capsule. You can call it neck fracture. You can call it intracapsular fracture. So it's non-displaced here. And then here we have an trochanteric fracture, so it's moving from greater trochanter to the lesser trochanter here. So it's an extracapsular because it's outside the capsule of the joint. We call it extracapsular. We can call it intra-trochanteric fracture as well. So now we have this non-displaced extracapsular subtrochanteric. So subtrochanteric is 5 centimeters below the greater trochanter. We call that subtrochanteric, and below that we have the shaft, right? So this is a subtrochanteric fracture of the femur. And these all are non-displaced fractures, right? So let's here talk about a little bit about the physis, right, or the epiphyseal plate. So this is the epiphyseal plate, which is also known as the. Actually, if it were here, this is not present here. So if it were present here, it would have been here. So this would have been a capital epiphysis. Then another epiphysis is present here. That is known as trochanteric epiphysis, and then one is present here in the pubis. So that is for the growth of the pelvis, this is for the growth of the head, and that is for the growth of this shaft. So these three are the plates, the epiphyseal plates, which are present in children only. Before the age of 15 to 18, they disappear. So now we're going to talk about some of the symptoms. So patients with and how we move to to radiological diagnosis, and we're going to see. So if someone presents with pain or swelling or some deformity, which is as a result of some trauma, then we move to radiology, or we look to diagnose the fractures or any displacement or any underlying impairment that has resulted because of some trauma. So we do X-rays first. So we have some views. We have AP, we have lateral. So for pelvis, AP is the ideal. For the femur, we have AP, we have lateral, and for this is the for the hip joint actually. So for a hip joint, we have AP or a lateral can be done, but it's not very common. And also there are some special views that we're going to just talk about. So this is again a hip dislocation. This is again a posterior and superior dislocation, which is the most common. The posterior dislocation is the most common, which is often associated with some superior dislocation or subluxation of the femur. So again, this is the acetabulum. The femoral head should have been here, but it's displaced posteriorly and superiorly as well. So now here we have a cross-section, again, a CT scan. So this is a cross-section, and again, comparison is the key to the diagnosis. So here we couldn't really diagnose these fracture sites of the acetabulum, right? But here, these fractures are very visible, right? So there are actually fragments here. This is a comminuted fracture of the acetabulum. And what's happening here is that you see here, this is the femoral head and the greater trochanter. So because this slice doesn't really show their connection, it's not like this connection is not present. It's just a little bit below this point. So this is a point where this isn't part of the slice. So slice is such that this is not visible. So right, these are actually joined together. This is the greater trochanter and the femoral head. These are joined together, but the joint is not visible here. So I hope that's clear. So this is present, but underneath here. So it's not present here. It's not visible here, but it's present. So here the joint is actually visible, right? So because it has actually displaced superiorly, even at this cross section, this joint is visible. So you go a little bit more in depth here, and you will see the entire bone actually connected. That should be visible a couple of slices down for normal. So this is normal, and it is not visible here because it's not moved superiorly. So when this bone has moved superiorly, now the connection is visible even in this cross section, right? So the connection is actually, this is the normal and this is abnormal. It shouldn't be visible here. This shouldn't be visible. This should have been here, and the connection should have been visible in the next couple of slices below, going down. So that is the acetabular fracture and some displacement or dislocation of the hip as well. So now here we're going to talk about femur. So before doing that, let's just focus a little bit on something that's very important. Like I said in the introduction, that I'll talk about the differences between a female and a male pelvis, right? So here I'm going to just give you an idea. So what happens is that the ring here is heart-shaped for males, and it's sort of like an oval shape for females. Then what happens is the sacral vertebral bodies are bigger for males and smaller for females. The height of the pelvis is actually more for males and less for females. The width of the pelvis is actually more for females and less for males. So these are some of the distinguishing features. And then this angle also is more for females, which actually increases when a female is pregnant. And also the space also is more for females, which increases up to 9 mm in pregnancy. And that is a little bit about the anatomical variations of pelvis in males and females. And again, let's repeat. Okay, so the female pelvis is wider and shorter. Male pelvis is taller and is comparatively less wider or less in width. So the sacrum or the sacral vertebral bodies are wide or broad for males and are sort of like not that broad for females. The pelvis ring is actually bigger for females and is smaller for males. It's actually heart-shaped for males, and for females it's oval-shaped. And then again, this angle beneath the symphysis pubis is actually more for females and less for males. So these are some of the differences that can help you in differentiating between a male and female pelvis. So now let's move towards the fracture. So again, let's label it first. So this is the ilium, the acetabulum, the pubis, and the ischium. So this is the femoral head. Let's look at the normal first. So ilium, acetabulum, ischium, pubis, the head of femur, the greater trochanter, the lesser trochanter. So what's happening here is that it's normal, right? So when you compare it with this, again, I'm emphasizing again and again that it's very important to compare, because then it's very easy for you, right? So this is normal, and then this is moved upward, and this entire the entire femur is now not continuous with its head, right? So the head has completely separated from the rest of the bone. It has displays superiorly and anteriorly as well. So this is placed anteriorly and superiorly, and the head is behind it or posterior to it, and is in the normal position here. It's in its anatomical position, same as this, but this has moved up. So this is a fracture of the neck of femur. So a lot of actually tendons and ligaments and muscles are actually pulling it up. So now we're going to talk about intertrochanteric. First, let's label it again. Acetabulum, femoral head, neck of femur, greater trochanter, lesser trochanter, the shaft of femur. This is going to form the ilium, and this is ischium and pubis here. Pubic symphysis isn't really visible. This is the sacral vertebral bodies. And coccix moving forward, the diffused ones are called coccix. So now here, between the true trochanters, the lesser and the greater, and the lesser is actually inferior, and greater trochanter is superiorly. So any fracture between them or connecting the two trochanters is called an intertrochanteric fracture. So inter is between, right? So that is how it's named. So this is an intertrochanteric fracture here. So now we're going to talk about some of the treatments. So you can actually go for an internal fixation. For that, you have to incise the skin, move the muscles. Sometimes you have to actually slice the muscles as well, and then repair them. And what you do is you insert screws and an internal fixator here, and this is how you actually hold the entire femur bone together. So the fragments then they can ossify because it's a weight-bearing joint. The ossification, or actually the repair of the fracture site, is actually complicated, and it depends on a lot of factors like the age, the gender of the individual. So internal fixation is a treatment to complex or really severe fractures. And also an arthroplasty, which happens in very severe cases or in old age. What they do is they take out and they do an osteotomy, and they take out the head and all the areas of the bone which were actually degenerating or were severely fractured. So here we can actually see the fragments of the fracture. So this is a new arthroplasty. So this is how they insert this is a total or complete arthroplasty in which there is a acetabulum, which is a foreign acetabulum. It's not the natural acetabulum. We've actually made this acetabulum artificially, and then we have made this head like femoral head like structure, and then this is actually inserted inside the shaft of femur. So it's drilled. The shaft of the femur is drilled first, and then this is inserted inside the shaft, and then this acetabulum is inserted inside the pelvis bone with screws, and then you place it inside. So that is how an arthroplasty, in very layman terms, is how you actually perform an arthroplasty. So that was a little bit about the treatment of complex hip fractures or complex dislocations, because there are a lot of pulls and on the bone fragments. So this can be a very good option. But this itself can be with a lot of other complications. You're actually incising the skin, you're actually incising a lot of muscles, and you're drilling inside the bone of an individual. So natural is natural, and when you have something that's man-made inside you, then it's different, right? So now we're going to talk about pubic rami. Let's look at the radiograph. So this is the pubis, right? The superior rami of, let's just ignore this for a minute, right? So again, let's label it. So the ilium, because it's not visible here, let's do it here. So the ilium, the sacroiliac joint here. Then this is the acetabulum, the femoral head, the greater trochanter, the lesser trochanter, we have this ischium here, and the pubis. This is the superior pubic rami. And again, comparison. When you compare both of them, it's visible that this has been fractured through and through, and this is placed interiorly and it has moved posteriorly. There's also some fracture here. Symphysis pubis seems normal. So now so this is an opacified or opacified urinary bladder. Let's not talk about that right now. So that's just, there's just opacity there, that's it. So this is actually the fracture, and now we're going to talk about the symphysis pubis. Like I said, so symphysis pubis is the inferior joint between the two pubis bones of the pelvis, right? So the normal distance is 4 to 5, and 5, you can actually say 4 to 6 can be normal, but anything more than that, especially in males, is not normal, right? So this is an AP, like I told before, like I said before. So it's AP is the ideal view for the pelvis, and everything can be visible from AP view. So let's label it again. So ilium, ischium, pubis, sacroiliac joint here and here, so sacral and coccyx. Then we have this femur, 2 femur bones, and then this is where the pubic symphysis is, right? So this is cartilage between it, so it's cartilage joining the two bones. So any wideness here will be obviously a fracture of that cartilage that is present between these two bones. The cartilage is obviously not visible on an X-ray or a radiograph. So this, if it's more than 4 to 5 mm, or if it's even if it's more than that in a female who's not pregnant, so that'll be a sign of a fracture. So like we just discussed before, so the normal was very close to one another, right? So the cartilage is not very thick. This is an obvious fracture. And now here we're going to look at a CT scan again. So again, here this is a CT scan, a cross section, and this is done so that you can actually visualize this will be here, right? So this is something here, the cross section of the body is taken, and this is increased distance, is showing an increased distance between the two pubis bones, which form the symphysis pubis. So this is how you see it on a CT scan cross-section. Now we have comminuted femoral shaft fracture. So comminuted fracture is when you have multiple fragments of the fracture, right? So let's see how that appears on the radiograph. So this is how comminuted fracture appears. It can be worse than this as well. So this is a fragment here, and then a little fragment here, and then one here. So this is actually the upper part here. This is a fragment. This is a fragment here as well. So this is another fragment. One here, small fragment here, and then one big fragment here, and then one small here. And this is the rest of the femoral shaft here, right? So overlying immobilizing device, so that is the traction device that you apply to fractures like this, right? So this, ignore this, this is nothing, this is just an immobilizing device. Now again, this is actually a fracture in a void-bearing position. This probably would have been very painful. So this is the upper femur, this is lower femur. We can actually see calcaneus here, and this is we can actually see the tibia here and the fibula a little bit, and this is the patella, right? So patella, the femur, the tibia, and fibula. So let's ignore the tibia and fibula for now, also the patella. So, but this is actually femur, and this is the fracture site, right? So we are actually calling it a comminuted fracture because this is actually the lateral view. This is a lateral view. So there can be a fragment here when we view it from the AP view. But here it seems as if this is another fragment, and these two are separate fracture segments of the bone. So this is a comminuted fracture of the shaft of the bone. This is a lateral view, and it can. It is probably the patient is lying actually, and it's not weight bearing. So first I thought it was weight bearing, but it's not. It's actually somebody who's lying, and the lateral aspect of their thigh has been focused, and then you have this lateral radiograph. Now we're going to move to the chronic conditions. So all of the acute conditions we've covered up until this point. All the fractures have been, different types of fractures have been discussed, and now we're going to move to the chronic conditions. So soft tissue masses, like I said. So let's see what we're going to discuss in the chronic conditions. So we're going to discuss arthritis. And this is arthritis. So we've been discussing arthritis in all of the lectures. What happens is that there are different types of arthritis. There's RA, there's OA, and sometimes we also discuss psoriatic arthritis for the wrist as well. So now we're going to talk about a little bit of different arthritis in the hip. We're going to look at the labral tears. So labrum is like we talked about in the introductory section as well. So labrum is something that is a structure that deepens the acetabulum for a more surface area to actually cover more part of the femoral head, right? So to encompass more femoral head, there needs to be a deepened acetabular fossa, right? So to deepen the acetabular fossa, we have this labrum. So we're going to see how its tears appear on a radiograph or on an MRI. Then we're going to talk about some stress fractures. Stress fractures are as a result of constant stress on joints or surfaces or bones. So we're going to see how that appears on the radiograph. So this is how the labral tear actually appears on a radiograph. So this is labral tear. So what happens is you see double lines. And we're going to discuss that in detail, and everybody will be clear on this as well. So then we're going to talk about some avascular necrosis. So avascular necrosis is when, due to blood supply, anything that is causing not an adequate supply of blood to the joint and not an adequate supply of nutrients to the joint, the bone actually starts to die. So that is basically avascular necrosis. Here we have the avascular necrosis. So what happens is, because the blood supply to the head or any segment for here, the head is inadequate. The head is not supplied with the adequate amount of nutrients in the blood that is required. So it starts to die. So this is actually the bone. Actually, what happens, we discussed in the previous lectures as well. So what happens is, first there is more osteoclastic activity, and then there is more osteoblastic activity as well. So that is why first it appears sclerotic, and then it actually appears darker. So this is avascular necrosis. Then here we have a stress fracture, which is because of constant stress to the bone, and here there is arthritis, and here we have labral tear. So these are little small diagrams here. So we're going to discuss them in detail. So first, let's talk about the osteoarthritis, right? So arthritis can be of two types that can involve the hip. There can actually be any different types of arthritis which can actually involve the hip. So arthritis can be OA or RA. It can be psoriatic. It can be infective or excessively infective, or it can be actually some bone tumor that is accompanied with arthritis. So let's here focus on osteoarthritis. So osteoarthritis has some certain characteristics, which are its basic characteristics no matter which joint is involved. So those are same here, like we discussed before in previous areas of the body as well. So what will happen is there's going to be decreased joint space, there's going to be loss of cartilage, there's going to be sclerosis, there's going to be osteophyte formation, there's going to be loose cartilage, body formation within the joint, which will result in a lot of friction, which will further progress the degenerative process and actually accelerate the process altogether. So it's a very it's a cascade of these changes which happen in the joint as a result of this degenerative disease. It can be due to overuse, it can be due to age, it can be due to other factors like gender, or when in older females it's very common to have osteoarthritis of the knee. Hip is rare, but it's seen. So this is the hip osteoarthritis of this is actually a pelvis of a female. As we can see, this is sort of like wider and oval more, and these sacral bodies are like not that wide as they are in males. So this is a female pelvis, and this is a female radiograph of a female pelvis. So here we have the acetabulum and the femoral head. Here we have the femoral head and the acetabulum. This is the ilium, ischium, pubis, sacroiliac joint here, sacral bodies, coccyx here. Ignore these little lucencies here. These are because of the bladder. And so here there is sclerosis, there is obvious joint space narrowing, there is obvious osteophyte formation. So this is an osteophyte here. So this is how to diagnose a osteoarthritis on a pelvis X-ray. What you will see actually is sclerosis. What you will see is joint space narrowing. Even here in the pubis, we can see that there is joint space narrowing, which I said that symphysis pubis is actually wider for females, but this is reduced here, and there's sclerosis of symphysis pubis as well. So it's present everywhere. There is sclerosis here as well. So an osteophyte, we found this osteophyte here as well. So there is something happening here as well, this ossification here. So this is how osteoarthritis involves multiple joints and multiple bones of a person. So this, like we said, this is, like we established, that this is a female pelvis. So, and we actually saw all of the basic features of osteoarthritis on it as well. So this is an ideal OA radiograph. So now we have rheumatoid arthritis. First, let's talk about rheumatoid arthritis a little bit before going to that. So rheumatoid arthritis is actually an autoimmune disease, right? So what happens is that your own body starts to react. And it's actually more of a disease of the synovium rather than the joint surfaces or the cartilage of the bone. So it's more of a disease of synovium. Again, ignore these lucencies here. These are because of the bladder. So again, to differentiate between OA and RA, all of the signs will be almost same. So how do you differentiate between OA and RA? Basically, you do blood tests. So radiology alone cannot diagnose everything. You can diagnose fractures and what type of fractures, and you can see what you can actually tell a lot of things. But these are facilitatory tests. All the radiographic imaging tests are actually facilitating your diagnosis. They can never alone help you diagnose a condition. You have to run other tests. So blood tests for RA will actually diagnose RA, and then you can actually differentiate between OA and RA. But on an X-ray, you can't really comment if it's an RA or an OA, because you can never know if there are any rheumatoid antigen present in the body, right? So that's not visible on the radiograph. So Now we're going to talk about some of the views, right? So to evaluate hip, there are different types of physical examination or physical tests, or which are performed to see if there is any degenerative change going on. So if there's any crepitation, you actually palpate the joint. You put a hand on top of the joint, and then you move the joint to actually sense if there is any crepitation. You see if there is any pain or discomfort with any movement, so you do an evaluation of the hip. If you suspect some chronic disease, because what happens in chronic disease is that you're used to that pain stimulus, and then you don't really feel a lot of pain. So you do feel pain. Constant pain is a lot of people complain of constant pain, but the intensity of pain is actually not that much. So it actually is triggered when a certain movement is performed. So you have to differentiate if the pain is there on certain movements, because that'll help you in the end to reach some diagnosis, right? So you evaluate the hip if you suspect any chronic condition, because in acute condition you really don't need to evaluate the hip and ask the patient to perform certain movements unless you're expecting some minor fracture. You actually do perform some of the movements to actually say and comment if there is a fracture, because movements are really painful in acute conditions as well. But you don't really need a physical examination when you suspect a fracture, and if there is visible deformity, you will never ask a patient to perform some movement, considering if we have a fracture, we're suspecting a fracture, in acute fracture of the upper limb, we're never going to ask the patient to move their hand if we suspect that there is a fracture, right? But in chronic conditions, there is a need of physical evaluation because of all the reasons that I just stated. So after the physical evaluation, what you do is you ask for an AP pelvis. Like I said, AP pelvis is the ideal view for the pelvis. So you ask for an AP view. You ask for AP hip. So again, to visualize the hip, the ideal view is AP, which is interior posterior. So that means that the patient is lying flat on the surface, and the X-ray tube is falling from the interior and exiting the body from the posterior, and the cassette is present underneath the patient or on the posterior surface of the patient, right? So then we have frog leg position. It is to visualize the acetabulum and the femoral head. So what a person is asked to do is, let's just explain it here, so that'll be easy for me as well. So here, if a person this is called kneeling position, right? So if you kneel, actually kneeling is when you sit on the ground. So let's call it hook lying. That's acceptable, right? So hook lying. So when a person is hook lying, and then you push the knees away from one another. So let's just imagine somebody hook lying, and then you push those knees away laterally, and then you focus your X-rays on this area here, and the resultant radiograph will be something like this, right? So what you're doing, again, I'm going to repeat. So you're hook lying, you're asking the person to lie in a hook lying position. And then what you're doing is you're pulling the knees away from one another, or away from the midline of the body, or moving them laterally. And then you're placing like this. This is moved laterally. But then just imagine that this feet was here and the other feet was here. So, and both the knees were in opposite directions, right? So that was hook lying and then separated. And then if a radiograph was obtained, it would be something of this sort. So that is frog leg position, or the lateral hip, but it's obtained with the X-rays falling on the body at 90 degrees. So those are a little bit about the views. Now we're going to talk about specific stress fractures. So let's see how that appears. So this is a stress fracture. As we can see that the area next to this fracture is actually sclerotic here. So that is how you differentiate a acute fracture from a stress fracture. So and also history plays the most important part here. So if somebody says that I fell, and then you perform an X-ray or an MRI and there's a fracture, then that's an acute fracture. But if somebody hasn't fallen, but they're experiencing some pain with certain movements, and then weight bearing is uncomfortable for them, and also let's just make it easy, and they say that they sprint every day. So then first thing that will click in your mind will be stress fracture, and then when an MRI will come in, and you'll see the area next to the fracture is actually sclerotic, then you'll just diagnose it as a stress fracture if you've seen. So this is an MRI, and this is the bone scan that we talked about in the introduction as well. So what happens in bone scan is that any area that is, what you do is you give a radioactive material to radioactive contrast material to the patient, right? And then it accumulates to any area where there is any infectious process going on in the body. So if there is an infectious process going on here, which is actually not picked up on any modality because it's initial, then it will be picked up because of the nuclear scan or the PET scan. Why? Because the inflammation process actually starts right at the moment that there is something wrong inside the body. The inflammatory process starts, and nuclear scans or PET scans can actually pick up that inflammatory process, and then you can know where there is any problem going on, and that can help you in your diagnosis process. So this is how nuclear scan appears. So this is darker here and here, right? So as we can see, this is different from all the rest of the shaft, and this is normal here, and this is abnormal because there is increased activity here, there's increased activity here. So that's how you can pick some inflammatory process on PETs on a nuclear scan. So this is a radionuclide bone scan. We can also call it PET scan. PET is for a positron emission scan. That's a nuclear bone scan. You give radioactive material to the patient, and then afterwards you ask them to drink a lot of water to get it out of their system. So now we're going to talk about some severe hip stress fractures. So let's see how they appear. Actually, hip stress fractures, this is actually the repair that's visible here. So actually, let's imagine it here. So if there was a severe hip fracture, which is not really picked up by an X-ray, but it can be, so there will be increased sclerosis. Sclerosis will be visible, and then you're going to have to ask for an MRI to actually diagnose that or see how wide the space is between the fracture lines. So. And then what happens is, because if a person says that they're going to continue their activity, there's going to be continuous stress, and then what will result is that it will never repair, right? The stress fracture won't repair because they can't stop their activity for a very long time. And once the bone has actually experienced a stress fracture, then it's more prone to develop a much severe fracture on movement or repetition of that, of multiple movements that are actually, because you can never stop using your hip joint, right? You're gonna walk, you're gonna run, you're gonna have to run at some point, right? So you're walking every day, so you can't really take that entire movement thing out of the equation when we're talking about the hip joint. You can't immobilize the hip joint. You can, but it's very hard. It's not good life then. So what you do then is this is what you do. This is the arthroplasty. This is a total hip arthroplasty in which you actually insert an acetabulum and also a femoral head, a man-made artificial femoral head, and then you drill inside the shaft of the femur, and then you place the artificial or the external shaft into it, which is the head, and this is the acetabulum, which has been placed here. So sometimes you need to actually put in screws with the acetabulum, and sometimes you can glue it on the actual natural acetabulum. So again, layman arthroplasty. So now we're going to talk about, again, chronic conditions and how, what are the signs and how to diagnose and everything. So what happens is that what actually results in chronic pain or these conditions is actually sometimes the cancer patients are in constant pain, right? They are, because of their radiation therapy, they are constantly at risk of these chronic pains, and they almost always have chronic pain. So that chronic pain will actually result in bone pains, and then the entire cascade of degeneration will start. So that's the first part. And then we have some old trauma that can just become worse. So like I said, old trauma can be some stress fracture. It can be something that some fracture that actually repaired but is now painful. So that's also chronic pain. So then we have alcoholism. That is also one of the causes of chronic pain. Then we have steroid use. So steroids, when used in the start, they actually relieve of pain, and then in the end they cause a lot of problems, right? A lot of joint conditions. And then we also have sickle cell anemia. So sickle cell anemia is a disorder of the RBCs. What happens is that their shape is abnormal, right? That is sickle shaped. So that is visible here. So they're sickle shaped, and what happens is that when RBCs are round, they can actually squeeze through spaces, right? But when they're sickle shaped, what happens is that they get stuck, and then they can't really travel through in different very small arterioles, if that makes sense. So if the arteriole is very small, they can't really pass through. And because nutrient arteries actually have a lot of very small branches, so that is why sickle cell anemia actually results in avascular changes or avascular necrosis, if very severe, in some bones. So this, and if there are any of these causes, then you actually ask for an MRI and to diagnose. So this is a avascular necrosis visible here and here, and also some changes happening here. So this is actually an MRI of a person who has sickle cell anemia. So their sickle cell anemia or their impaired RBCs are actually impairing the blood supply to these areas of the bone, and that is why the process of dying that has actually started happening on both the femoral heads and here as well. So now we're going to talk about some of the changes in kids, right? So pediatric causes of chronic hip pain. So chronic conditions can actually occur in children as well. So there are two conditions that we're going to discuss. The first one is we're going to talk about the leg calf Perthes disease. So what happens is it's avascular necrosis, and it can actually happen because of some injury to the hip. So it's not something that a kid is born with. So because of some injury to the hip, what happens is that there is disrupted blood supply, which impairs the growth of the bone, because obviously in kids there is epiphyseal plates, and which will result in impaired growth. So that is like cleft Perthes, and this is normal and this is abnormal. So if this is a kid, and this is actually the capital epiphysis here and an epiphysis here as well. So this here is completely necrosing, or not completely necrosed, but is necrosing, is in the process of dying. So if you have a kid who presents like this, so ignore this is because of the bladder. So again, if a kid presents with something like this, again, comparison will help you suspect like calf Perthes disease. Then the second chronic condition is the slipped capital femoral epiphysis. So femoral epiphysis is present here in the head. So what will happen is if it slips, this is present here. So what will happen is when it slips, the capital, the head will stay in its place and the rest of the bone will actually slip away. Or it can actually happen vice versa as well. So the rest of the bone can actually stay in place, whereas the head can actually move up, or down, right, left, or you can actually call it medial lateral or superior inferior as well. So the diagnosis is like this. So here we have the movement is actually of the head here. So this should have been here like this. So it would have been better if we had this entire picture, but let's just focus here. So the greater trochanter is not visible here, but actually the greater trochanter is behind. So this is actually the head, the corner of the head, right? So this is present here, very close to the acetabulum, and here we can't really see it. So it's actually translated upward and is not present, right, like is not in continuation here, because we can see that this is completely disrupted, right? So there's a gap here. So this is the plate, but the rest of the head is moved up. So that is a slipped capital femoral epiphysis. Again, the growth will be impaired. So these are the two chronic conditions that are present in kids. So now we're going to talk about the clinical presentation. So the clinical presentation will reveal us to chronic pain. So we talked about a lot of different conditions. So if a person is alcoholic or anemic, has sickle cell anemia, or is a kid and presents with chronic pain in the hip, what we do is we suggest a X-ray, and then we see different changes, and then we diagnose the patient. For here, it's an osteoid osteoma. So what will happen is it'll be very opaque, right? So it'll be very bright. For a layman, it'll be very bright or opaque. So it'll be sclerotic, and obviously you can do nuclear scans for it. So this is an osteoid osteoma here. What will happen next is a CT scan will be done. So in a CT scan after an X-ray, if there is a lot of sclerosis, if there's a lot of bright activity going on, then you suspect something is wrong, then you go for a CT scan or an MRI, or you can actually go for a bone scan as well. So depending on what you're suspecting. So everything will matter. The history will matter, the clinical presentation will matter. So that'll help you, but radiology will be a facilitating entity in itself. So now we're going to talk about labral tears. So like we discussed, the labrum is deepening the joint. So what happens is when there is a labrum tear, we see a double line right in the middle of it, or sometimes here we see a double line. So labral tears are actually visible on X-rays in the center and on CT scans or MRI here. So there is changes in these areas. We see a double line here and here. So this is some labral. We suspect some labral issue here as well. So we can actually suspect this double lining here. So because this is not like same as here, right? So there is like this protrusion that actually signals that there is something wrong with the labrum. And then also here, there are changes here. So what will happen is when there is some labral damage, there will be a click on movement. So the leg will lock and then unlock, lock and then unlock, and with that there will be a click, a clicking sound. So that can also help you with your diagnosis of some labral tear. So we're still discussing labral tears of the acetabulum. Let's see this. So this is an MRI. So what we see here is the labrum is not continuous here. So this here is it has some hypo intense areas in between here. So this is actually visible on an X-ray, but these are not really visible here. So this labrum here, you can see this is the end, right? So it's disrupted here. So that is how you pick it up on an MRI. Obviously, there is going to be some clicking and all of those things as well to help you reach your diagnosis. So now we're going to talk about some soft tissue masses. So soft tissue masses can be anywhere in underneath the skin, right? So or anywhere really. So this is a soft tissue mass. This is a cross section, and again a soft tissue mass here as well. So how you pick it up is it's depending on the sequence that you're using. It's either hypo or hyper. So these are two soft tissue masses. These are actually when you look at a region in the body, you can actually see some sort of like a protrusion, and sometimes there is a palpable little nodule underneath. It can be something that is like pressable, and sometimes it's painful. So it depends on different types of soft tissue masses. You can actually do, if you suspect something, you can actually do a biopsy of it, or you can actually take it out as well, because it's just underneath the skin. It's in the right next to the muscle. So it's above the muscles, right next to right underneath the skin and above the muscles. So now we're going to talk about intra-articular lipoma. Lipoma is fat, made up of fat. So intra-articular is like inside the joint. Again, here I will emphasize on comparison of the two sides. So here, unfortunately, there's an arrow. If there weren't an arrow, then like divide this in half and then start comparing. Like this is present here, same. Okay, this in half is actually same as the other mirror images. It's present here. Okay, this seems normal. This is some muscle or tendon. Okay, these are muscles. These are 3 present here. Okay, so this is also present here. And then bones are same. But then there is this structure right next to the bone. It's not present here. So that's different, right? So then you suspect, and then you look at it, and it's when you do certain other sorts of tests, and you suspect, and there's also history, and then other sort of things as well, and then you suspect a lipoma. So if it turns out that these are fat cells, then it's a lipoma. So here, this is how you kind of differentiate between something that's abnormal by comparison. So this is actually a cross-sectional image, right? So this is how you, this is actually the femur here. So it's actually inside, right next to it. So now we're going to, again, talk about a little bit about osteoarthritis. So this is an advanced DJD. So DJD is degenerative joint disease, also known as osteoarthritis. We talked a lot about it. So what happens is there is sclerosis, decreased joint space, degeneration of the cartilage, osteophyte formation, and let's see all of those here. So this is joint space narrowing, there is sclerosis, there is osteophyte formation here, and this is how an advanced DJD is presenting. So what happens is there is almost no joint space, and the movement will actually create crept, and there is visible these cartilage ridges here that will actually increase in the friction and the movement. See here, this is not like a smooth surface. It has these irregular. So this here is very pointy. See, so this here, focus on this area, and it's really pointy. So that'll create a lot of friction and problem and impingement, and then obviously inflammation. So this is advanced degenerative joint disease. And then we have hip replacement for this condition. So what happens is we consider a lot of things before moving to hip replacement. We consider the age, the severity of osteoarthritis, because this bone has to hold it in, right? So if it's damaged here, then it won't be able to hold this entire fixation of the replacement of this head. It won't be able to keep it. inside it. It won't be able to hold it, right? So if this is not strong enough, then we can't really perform a hip replacement. So it has to be performed it's better to actually go for hip replacement when the condition is not very severe, because this bone has to hold it in, and if it can't, then it'll fracture, and that'll create a much worse case, right? So you can't really do it in patients who are really old or really frail or have really degenerated entire bone of the shaft as well. So that's a little bit about hip replacement. Now we're going to talk about shaft fractures. So this is femoral shaft, and fracture, so this is an MRI, right? So because the cortical bone is darker, so MRI, and these here are fracture sites. Again, history and presenting complaint will play a part in your diagnosis. So now this is a T2 of coronal MRI. Again, cortical bone is darker, so it's a T2 MRI. So what happens? What is visible here is these are the changes here. So this is a fracture of the head and not the shaft here. So shaft is this, and this is actually the head. So it's a fracture here. So this is more suggestive of a stress fracture. It's a stress fracture here because there's sclerosis here as well. So this is a stress fracture in T2 sequence of MRI. So now we're going to talk about avascular necrosis. So avascular necrosis is because there is not an adequate supply of blood or nutrients to the bone area, right? So this is how on T2 sequence of an MRI, so T2, what happens is the cortical bone is darker, and so this is the obvious abnormal area here. So what we suspect is because there is visible hypo intense areas with hyper intense as well. So what this suggests is there is some osteoblastic and clastic activity going on, which is actually characteristic of the death of the bone and all that activity. So there is a depression forming here, and then it'll progress to the entire bone if not stopped, and if the nutrients are and the blood is not supplied to the bone. So this is a T2 coronal or frontal view. This is a hypointense subarticular line here, and then there are some hyper areas as well. So again, we're going to still talk about avascular necrosis a little bit. So again, we're going to talk about why there's a need for hip replacement. So because it's a chronic condition, right? So there's going to be pain, but sometimes people actually ignore it and they don't really report it or people aren't really paying attention to it and they're not diagnosed. So what happens is there is advanced necrosis, there is advanced cell death, bone death. So what will happen is the bone will not be able, it won't be something that you can save if it's advanced, right? So then obviously you'll have to move to arthroplasty, and again it's very important for the rest of the bone to be adequately supplied with blood and nutrients for it to be strong enough to hold the external fixation here. So now we're going to talk about the capital femoral epiphysis. So capital femoral epiphysis is the upper or the superior epiphysis. So the second one is present here, which is trochanteric. So this is the capital one. So if it slips, two things can happen. Either the shaft can move away or the head can move away. So they can both happen together as well. So we discussed this before as well. So this is a slipped capital femoral epiphysis. So now we're going to move towards bone tumors. So this is the end of all the chronic conditions. So let's see some things about the bone tumor. So this is the femur here, and these are the periosteal reactions. So periosteal is the outer layer, right? So there is this sclerotic activity visible here and here, right? So these are the blastic bone tumors. The blastic bone tumors here as well. And then there is this area has been completely dissolved, right? Not completely, like partially dissolved with areas of blastic bone activity going on. So this is how a bone tumor is visible on the x-ray. So that was the end of our chronic conditions as well. So with that, we end our today's lecture on the lower limb. We discussed the acute conditions, the acute fractures. We discussed some chronic conditions and some stress fractures, as well as arthritic conditions, and some bone tumors and soft tissue masses. So with that, I end today's lecture. So please watch other videos on a radiology series on sqadia.com. And that's it for today. Thank you for watching.